Hey everybody, it's Miss Smedley again. Today we're going to go over the heart for your physical assessment. If you'll let me just get this pulled up for you into a slideshow. Okay, here we go. We're going to do the heart and the neck vessels today. There is not a lot of assessment that will be on your checkoffs for the neck vessels, but you do need to know how to do those for when you get into the clinical setting. First off, you need to make sure that you read this chapter, okay? Review your structures and function of the heart and the neck vessels, because we're not going to go into these very much. You need to think about the heart as an upside down triangle in the chest. The top of the heart is the broader base, and the bottom is your apex, which points down and to the left. During contractions, the apex will beat against your chest wall, producing that apical impulse that you will need to be palpating. It's at the fifth intercostal space left of the sternal border. The right side of the heart is anterior and the left side is posterior, so it sits kind of sideways in your chest, okay? So let's get started. What parts of the assessment do you need to know before you get started on the physical aspects? That's your subjective data. And I have a list here for you. You need to ask the patient to describe the onset, location, and any characteristics of chest pain if they are having it. If it's a description of a clenched fist or a squeezing type of pain, that's usually characteristic of angina. Assess where the pain, what brings the pain on and what worsens it or relieves that pain. Next is your dyspnea. You need to assess the onset, the duration, what position they're in when are they lying down, what most affects that feeling of dyspnea. How many pillows does the patient need to lie on at night for the orthopnea? Okay, check for presence of cough, and if they have one, how long have they had it, and how often do they cough? What's the intensity of that cough, the characteristics? Do they produce sputum with it? On fatigue, when did it start, and does it interfere with their work and keeping up with their friends? Note any cyanosis or pallor in their face. Do they notice their face turning blue or ashen at times? Assess the onset and amount of any recent changes in their edema. You want to check for nocturia. Is there any changes in their urination? Are they going more frequently? Are they going less? Are they having any difficulty with their stream? Is there a family history of any cardiac disorders? Do they have any cardiac disorders? Find out when they had their last ECG, when they had their cholesterol checked, and if they've had any other heart tests completed and what those results were. You want to also assess their nutrition, their smoking habits, alcohol use, their exercise patterns, and any drug use. And if they're on medications for their heart or their blood pressure, are they compliant with these medications? If not, what's the cause of this? Is it they don't have any money? They don't have any way to get their medications? These are the things you need to find out for. In infants and children, you need to assess their growth and activity to ensure that they are at their expected levels. Assess for respiratory infections and any congenital abnormalities that these patients might have. In your aged patients, do they have heart and lung disease? If so, how is it being treated? Any medications they're taking for illnesses, and environmental factors such as, especially in the older folks, is there stairs in their home that they're going to have to cope with? Okay. Now, the skills that you need, and as you can see here, I've put them up, and those of you that are visual, hopefully these pictures will help a little bit. You're going to do inspection, you're going to look at everything, then you're going to do palpation, and then you're going to do auscultation. If you'll notice here, it doesn't say anything about percussion. percussion used to be done to outline the heart. However, it's not done anymore because they use chest x-rays and echoes to visualize the size of the heart. The equipment you're going to need is a marking pen, a small centimeter ruler, a stethoscope with a diaphragm and a bell, and alcohol. And make sure that you know how to operate, if you have a single head stethoscope, how you operate it to perform it as a bell. Okay? Now, I put on here a slide that says the order of regional cardiovascular assessment. Your assessment for cardiovascular is kind of a little bit different. You're going to start at the most peripheral points and you're going to work your way in. This is more logical, correct? You start with your pulse and your blood pressure, and on your assessment you're going to be doing these before you come in. So, you know, you've already stated what their pulse and their blood pressure is. You want to look at the extremities, look at the nail beds, look at the fingers, look at their arms, look at their legs. Then you're going to check the neck vessels, and then you're going to go to the precordium. Okay? Now let's get started. You're going to inspect the carotids. You want to have that person sitting up, right? You're going to start this part of your inspection, or this part of your physical assessment, right after you get done with the lungs. So have that person sitting up. You want to stand on their right side. It's going to help you facilitate your hand placement if you're on the right. Okay, look at the neck veins. After you look at them to see if there's any excessive force in the pulsations, then you're going to want to auscultate. Okay? You're going to palpate gently one carotid artery at a time to prevent compromising the arterial blood flow to the brain, of course. Feel the contour and the amplitude of the pulse. It should have a brisk upstroke and a slower downstroke. Okay? Auscultate each carotid artery. Like I said, avoid compressing with your stethoscope the artery. It could cause you to have an artificial bruit, and it could compromise the circulation to the carotid arteries, especially if they're already narrowed with any atherosclerosis. Ask the person to take a deep breath, exhale, and then to hold briefly while you listen to, so the tracheal breath sounds do not mask or mimic a bruit. Okay? And when you're having your patient do this, you're going to want to hold your breath with them. That way you'll make sure that you aren't having them hold it too long while you're trying to focus on listening for the sounds. Auscultate the carotid arteries for presence of bruit. It can be a blowing, swishing sound. Okay? This indicates that blood turbulence, and it's not normal for you to have any turbulence. The neck should be in a neutral position when they're doing this. You want to lightly apply that bell of the stethoscope over the carotids in 3 areas, as you can see in your picture. Here you have 1, it's right up at the jawline, 2 is about midway through, and then 3 is right up above the clavicle. Okay? Like I said before, you want to avoid that excessive pressure in the neck, especially in the higher one where it says number 1 here, because you can cause an excessive vagal stimulation there, and you can slow the person's heart rate down with that. Now, your JVP, you're going to be standing on the right side of the person. That gives you a better form of assessment. This is not on your assessment checkoff, like I said before. Your jugular veins are going to be assessed, and it helps you to assess your central venous pressure. it can help you. This helps you to assess the heart's efficiency as a pump. If you have unilateral distension, that's what you're checking for, is neck vein distension. It can be an external cause like kinking or an aneurysm. Okay. The location, you're going to look for pulsation of the interjugular veins in the area of the suprasternal notch or around the origin of the sternomastoid muscle around the clavicle. Okay, the location is lower and more lateral, under and behind the sternomastoid muscle than the carotid artery is. The quality is undulating and diffuse, and there are 2 visible waves per cycle. The jugular vein varies with respiration. It will descend during inspiration, and the internal jugular is non-palpable with light pressure at the base of the neck. In other words, you can easily obliterate this if you're pushing too hard. Okay, you want to position the person setting, and if they're setting, it should drop where you're not seeing it, or even disappear. When they're lying down, you'll be able to visualize it better. Okay, your book shows you how to estimate the JVP. You're going to, you need to be aware of this technique. It's good for, like I said, estimating the venous pressure. The reason why we don't do it in our assessment is it can be difficult to do, and a lot of times it's not a very reliable predictor of your central venous pressure. Consistency in grading is another problem they have. You know, each one of us is different, and we will grade differently on this. If you can't find the interjugular vein, you can use the extrajugular vein, and note the point where it looks like it's collapsed is where you're going to start this. Okay, you're going to hold a vertical ruler on the sternal angle. You're going to align the straight edge of that ruler like it's a T and adjust the level of the horizontal straight edge to the level of the pulsation. And this next slide shows you how to do that, okay? Like I said, this is not required on your physical exam that you're going to be taking with us, but you do need to know how to do this in case you get in the hospital and you have any questions. You might have a patient that you need to do this to. And the next slide is going to show you another test that you can do on your patients. It's a hepatojugular reflux, and this technique, you're going to have the patient laying comfortably supine. You're going to instruct them to breathe quietly through the open mouth. You want to hold your right hand, as you can see here, on the upper quadrant of the person's abdomen, just below the rib cage. You're going to watch the level of this jugular pulsation here, and you're going to push your hand in. You're going to push pretty hard, okay? So tell them it's going to be uncomfortable. You got to exert a firm pressure and hold it for 30 seconds. It's going to displace your venous blood out of the liver sinusoids, and it's going to add to the volume in the venous system itself. Up here, you're going to see distension, okay, on your physical assessment. And this should, if the heart is pumping effectively, only last for a couple of seconds until it recedes and goes back into its previous position. Like I said, this is not going to be on your assessment. You just need to know, be familiar with it. Now, we've done the neck veins. Let's move on to the procordium. You're going to inspect the chest. What are you looking for? You're going to use a tangential light. You know what that is? That's where you actually hold the light to their side and let it go across their body, okay? you're going to be looking for any heaves or lifts that might be, you can see the shadows of these as that light goes across. Okay? A heave or lift is a sustained forceful thrusting of the ventricle during the systole. The right ventricle heave is seen at the sternal border, and your left ventricle heave is going to be seen at the apex. Okay, you can also look on table 19-9 on page, I believe it's 501, to see where it shows you where you will detect the heaves and the thrills. You're going to next assess your apical impulse, your PMI, that's point of maximal impulse. Okay, localize your apical impulse precisely by using one finger pad, as you can see here in the picture. Ask the person to exhale and hold it, and this helps in locating that pulsation. Okay, you may need to roll them up midway on their left to find it. This is going to displace the apical impulse a little bit further to the left, though, when you do that. So don't expect it to be where you would normally find it. Okay, the apical impulse is palpated in about half the adults. A lot of the adults, you won't be able to palpate it if they are obese or if they have thick chest walls, such as someone that has COPD or in a large-breasted person. Okay? When a patient has a high cardiac output state, they're going to have anxiety, like anxiety, fear, or anemia. The apical impulse increases in amplitude and duration. An enlarged heart can displace your PMI down and to the left. A sustained impulse with increased force and duration in the same location is normal, and it's indicative of your left ventricular hypertrophy without any dilatation. Like I said before, your PMI may not be palpable in someone that has emphysema or some overlying lung disease. Okay, you're going to note the location of it. Like I said, where did you find it? It should apply only to one intercostal space, and it's going to be medial or to the left midclavicular line, about 1 to 2 centimeters. The amplitude should be a short, gentle tap, and the duration should be very short. Okay. Next, you're going to palpate across the procordium. You want to use the palmar aspects of your fingers. You're going to search for any pulsations that are not normal. If any are present, you need to note the timing and the location of that pulsation for your doctor. And like I said, they used to percuss the borders or the chest for the borders of the heart so they could kind of outline it, but anymore they do not do that. They do chest x-rays and echocardiograms for those. Okay. Now we're going to move on to the auscultation, and this is the part of your assessment that we really pay close attention to on the heart aspects. So you need to make sure that you get this part down correctly. Now, when we do assessment, we're going to assess you for the traditional, which is this one right here. Okay, your aortic, your pulmonic, your Erb's point, your tricuspid, and your mitral valves. And if you will, a mnemonic that helped me way back when I was in school is a practitioner earns their money, because this is the way you're going to assess them. A is for your aortic, P for the practitioner, pulmonic, earns, E is your Erb's point, the T for there is your tricuspid, and the M for mitral is, or M for money is mitral valve. Okay, now these valves are not actually located at the sites where you will hear them. Okay, the sound produced by the valves are best heard is the points that you're going to be using. they radiate in the direction of the blood flow is the reason why you don't, you hear them at typically strange areas. Okay? Look closely at your checkoff sheet. You need to perform your auscultation to specific areas with the patient and the stethoscope. Okay? What I'm meaning by this is if you will look at that checkoff sheet, it will tell you that you will be doing this with both the diaphragm and the bell, with the patient sitting, lying, and on the left side. So you've got 2 times you're listening, and you've got 3 positions. On your checkoff, we have accepted that you would tell us that you would do it in the 3 positions, okay? But you still need to do it with both the diaphragm and the bell. Okay? The valves are located for the aortic. It will be the 2nd intercostal space on the right sternal border. Okay? Your pulmonic is your second left intercostal space on the left sternal border. Your Erb's point is the 3rd intercostal space on the left sternal border. Your tricuspid is the 5th intercostal space, lower sternal border. And your mitral valve will be in the 5th intercostal space at the midclavicular line. Okay? You need to tell your patient while you're doing this that you're going to be listening for a little bit of time to their chest, okay? And in several places, that it doesn't mean that there's anything wrong, that you just have to auscultate all of the valves, okay? Like I said, the sounds produced by the valves may be heard over the precordium. You're going to need to learn to inch your stethoscope, do a rough Z pattern on them. Start at the base if you want to with the aortic valve, and go over to your pulmonic, then down to your Erb's point, and then a little further down to the tricuspid, and then over to the mitral. Do that with your diaphragm, and then flip it over to your bell and go back up and listen with your bell. I think that would probably be the smoothest for you, but if you want to start at the apex and work your way up, that's fine too. Okay? When you place your stethoscope, on your patient, you're going to want to briefly close your eyes and concentrate and listen to the heart sounds, okay? Before you ever start listening to the valves, you'll want to make sure that you hear an S1 and an S2. Distinguish whether the patient has 2 heart sounds, 3 heart sounds, or 4 heart sounds audible. All right? If you note an irregularity, you need to check for a pulse deficit. So how do you do this? You're going to listen at your apex, and you're going to feel the radial artery at the same time. You want to count one and then count the other, and take the radial away from the apical pulse. That should always be the radial is a lower number than the apical, and then subtract one from the other, and that's going to give you your pulse deficit. Okay? Like I said, distinguish your heart sounds at S1 and S2. S1 is going to correspond with your carotid pulse, so if you have trouble distinguishing, if you'll just reach up and palpate the carotid artery as you're listening, then you can find the S1. Okay? Your S1 is the AV valves closing, and your S2 is the closure of your semilunar valves. Your AV valves are which ones? Do you know? Make sure you know the difference between the AV and the semilunar. Okay, S1 is louder than S2 at the apex, and your S2 is louder than your S1 at the base. Note whether each heart sound is normal, accentuated, diminished, or split. Okay? Although sinus arrhythmias occur normally in young adults and children, you shouldn't hear them in older adults. Every beat of your heart at the apex should perfuse to the periphery and be palpable. So when you're hearing them, you should be able to feel them as well. Okay? Like I just got finished telling you, the S1 is louder at your apex, S2 is louder at the base. The S1 is the closure of your AV valves. It signals the beginning of your systole. You can hear it over the entire precordium. Although it's loudest at the apex, it can be heard with the diaphragm, with the person in any position, and equally well on inspiration and expiration. A split S1 means that you're hearing the mitral and the tricuspid components separately, okay? It is audible in the tricuspid valve area, the left lower sternal border. The split is very rapid with the two components only being about 0.03 of a second apart, so sometimes it can be difficult for a newbie to pick up. All right, let's move on to the second heart sound. Like I said before, it's associated with the closure of the semilunar valves. When you hear a split S2, don't be tempted to ask that person to hold their breath so that you can concentrate on the sound, because by holding their breath it can cause the ejection to equalize and it'll go away. Okay? Instead, concentrate on the split as you watch the person's chest rise and fall with their breathing. That will help you pick up the difference. A split S2 occurs about every fourth heartbeat, and it fades on inhalation and will also fade on exhalation. Okay? Because of the effects of respiration on the heart, the aortic valve can close about 0.06 of a second before the pulmonic valve. So when this happens, instead of hearing the dub that you normally think of, you're going to hear a ta-dub. All right? Extra heart sounds, you want to listen with the diaphragm and then switch over to the bell, covering all your oscillatory areas. Usually these are silent periods. You may when you do detect an extra heart sound, you want to listen carefully and note the timing and the characteristics of it. A fixed split is unaffected by respiration. That split is always going to be there, okay? If you have a paradoxal split, it's going to be the opposite. The sound fuse in inspiration and it splits with expiration. A pathologic S3 occurs with heart failure or volume overload, and you can hear a pathologic S4 when someone has CAD. Alright, and you can see all of these on table 19-4 through 19-7 on pages 496 through 500. Alright, let's go on to murmurs. A murmur is a blowing, swishing sound that occurs with turbulence in blood in the heart and the great vessels. Except for innocent or functional murmurs, murmurs are abnormal. All right? You will see innocent and functional ones mostly in children. A systolic murmur may occur in a healthy heart or with heart disease. A diastolic murmur always indicates heart disease. S3 and S4 and a murmur are often heard in mitral stenosis. Sometimes it can only be heard when the patient is lying on their left side, so you need to pull them over to that left. Like I said, you've got 3 positions. A soft diastolic murmur could be an indication of aortic regurgitation. and it may be heard only when the person is leaning forward in that sitting position. Okay, so when you have them in the sitting position, have them lean forward slightly, and it will pull the heart closer to the chest so you can hear it. Now, in murmurs, you need to be descriptive about your murmur. If you pick one up, you need to describe the timing, the loudness, the pitch, pattern, quality, location, radiation, the posture, and if there's any change in position. Look at the timing and the loudness information on page 484. Okay, timing defines the murmur by its occurrence in systole or distally. Okay, you got to identify if it's in S1 or S2. You got to be able to identify S1 and S2 accurately to be able to do this. Now, on these, you're also going to grade your murmur. A grade 1 murmur is barely audible. It is heard only in a quiet room, and then you might have some difficulty hearing it. A grade 2 is clearly audible, but it's still faint. A grade 3 is moderately loud, and it's pretty easy to hear. A grade 4 is loud, and it's associated with the thrill that you palpate on the chest wall. A grade 5 is very loud, and it can be heard with one corner of the stethoscope lifted off of the chest wall. A grade 6 is the loudest, and it can be heard with the entire stethoscope still not placed on the chest. I mean, you put your bell on the chest, and then you lift it off, and you can still hear that murmur. Okay? You need to describe the pitch as either high, medium, or low. It's going to depend on the pressure and the rate of the blood flow that's producing that murmur, what the pitch is. The intensity may follow a pattern during the cardiac phase, growing loud, which is cassandro, and then tapering off, which is descendro, or increasing to a peak and then decreasing, which is called a cassandro descendro, or it can be diamond shaped. Okay? Describe the quality of the murmur. It can be musical, it can be blowing, it can be harsh, or it can be rumbling. Then you want to describe the area of maximum intensity of the murmur. Where do you best hear it at? Okay? You need to note which valve area or intercostal space you're detecting it at. The murmur may be transmitted downstream in a direction of blood flow and may be heard in another place over your precordium. So if you hear one, keep tracking it down, all right? Other sites that you can hear murmurs at would be in the neck, believe it or not, the back, and the axilla. Okay? After auscultating in that supine, you're going to have that patient roll towards their left side. Okay? Listen with the bell at the apex for the presence of any diastolic filling sounds, which is your S3 or your S4. Have that person sit up and lean forward slightly, like I was telling you, and have them exhale. Okay? Listen with the diaphragm pressed firmly against at the base, the right and the left sides. You want to check for any soft, high-pitched, early diastolic murmurs or aortic or pulmonic regurgitations. Some murmurs disappear or are enhanced by change in position. That's why you want to change their position so much. Some murmurs are common in healthy children and adolescents, like I said before, and they're termed as an innocent or functional murmur. The contractile force of the heart in a child is greater, and that's why you can hear these. That because the contractile force is so much greater in the children, this is what increases the blood's velocity going through the chest. Okay, that increase in that velocity in their smaller chest measurement is what makes the murmur audible. Generally, an innocent murmur is usually graded around a grade 2. Okay, it will be a mid-systolic, short, cassandro, descendro, and will have a variability and a musical quality to it. Innocent murmurs are usually heard in the second and the third intercostal space and disappear when the patient sits up. Okay? And usually these younger patients won't have any associated signs of cardiac dysfunction. All right. I know this, you probably felt like this is pretty quick. The heart is a pretty, believe it or not, small part of your assessment. I am also giving you, which I forgot to tell you on your last one, I am giving you some YouTubes for you to look at that might help you a little more than me just sitting here talking you through it. Again, if you have any problems whatsoever, I'm also going to stick up some recordings of different heart sounds for you to help you learn how to listen. If you have any problems, if you need my help at all, feel free to send me a message on Blackboard or to make an appointment, and I'll be glad to meet with you and work on this one-on-one if need be. I appreciate your time. If you, like I said, if you have any questions, you just feel free to see me just as soon as you possibly can. I'm always here for you.